Again, students, let us continue the topic. Forget the picture, concentrate on the topic. You will now understand why I have divided the carcinoma breast into two parts. The rest of the story is a bygone one. Classification is an aid to orderly thinking, we had already seen. And repetition is the mother of knowledge. I shall repeat the classification so that we will understand what is to follow. The tumors of the breast. The malignant tumors are divided into non-invasive and invasive carcinoma. Each of them are divided into the ductal and the lobular. So non-invasive, you have got intraductal carcinoma and lobular carcinoma in situ. Invasive, you have got invasive ductal carcinoma, invasive lobular carcinoma. And this is a panel of variants which you can have in an invasive ductal carcinoma. Forget not the pages which can be a question by itself and even otherwise important. This is a schematic picture of a ductal carcinoma. This is a normal duct that we see. The violet colored ones are the internal epithelium and the slightly bluish ones are the myoepithelial cells. The green line is the basement membrane. So this is the normal structure of any duct in a breast. In some conditions you find that there is a proliferation of the epithelium. This is called hyperplasia. P is for proliferation. After some time, it becomes a little uncontrolled and it starts proliferating even more and very disorderly. And this is called a ductal carcinoma in situ because the basement membrane is still intact. Finally, there is a breach of the basement membrane and the neoplastic cells spill over and infiltrate the surrounding the stromal tissue. And this is called infiltrating ductal carcinoma. Normal, hyperplasia, carcinoma in situ, and infiltrating ductal carcinoma. You will not only remember this, but you shall draw this. Again, a beautiful set of pictures that I managed to pick up. In the carcinoma in situ, all the four are carcinoma in situ pictures because the basement membrane, the last line, is intact. In this one, the greenish lines are the epithelial cells. I see some small infoldings, and this is called a micropapillary in situ carcinoma. As the papillary projections keep growing, they can coalesce and they join to form multiple sieve-like patterns. This is called a cribriform pattern. Eventually, the proliferation can continue so much so that the entire lumen is filled with the tumor cells. This is called a solid pattern. And there will be a central area of necrosis and it is called a comedo. Comedo is something like an acne or a pimple where there is an inner necrosis. All these are patterns of ductal carcinoma in situ. The same thing have been put into words. You can see them. Small papillary ingrowths knitted together to form a cribriform pattern, occupies the entire lumen to form a solid lesion, and then there is a central area of necrosis forming a comedo pattern. So this is not just spoon feeding, but a Ryle's tube feeding for you people. The contents are already in your stomach. You have to digest and reproduce it. As well as draw the diagrams. This is a histological picture of a comedocarcinoma. Histological pictures are always a little complex for the students. But anyway, you can see a duct which is filled with tumor cells and there are central areas of necrosis. And this is the stroma. The tumor cells are not infiltrating into the stroma. And the Latin word comedier means eat up. So something is eating up the tissue, there is some necrosis, and there is an in situ carcinoma with an area of necrosis. This is a facial acne from which there can be the necrosis which can be either removed or treated with various antiseptics. This is a kind of summary which I would like you people to memorize towards the end, but not as such. The various patterns are given. What is the gross picture that is striking? If it is not striking, I have just left it blank. And what is the microscopic picture? I shall be explaining the microscopy in the picture form, and finally what is the clinical outcome of it. This particular one is for a rapid revision. I would like you people to see this towards the end and also before the exam. What can be the symptoms of a breast cancer? Look at the picture over here. There is a retraction of the nipple, and the age also you people can judge. It is a lady around the menopause, and the areola as well as the surrounding skin, it shows an eczematous change. Eczematous change where there will be encrustation, peeling off. What are the other symptoms that can be seen? Obviously, there will be a lump that is fixed. There can be a dilatation of the veins. There is an inversion of the nipple. Discharge, sometimes a hemorrhagic discharge might be there, and axillary lymphadenopathy. These are some of the features which are again mentioned over here. So you people can go through the list. What is the microscopic picture of an infiltrating ductal carcinoma? Earlier we had seen an intraductal carcinoma. The tumor cells may be seen in the form of nests or glands. See, nests. These are all nests of tumor cells. Again, another long elaborated nest is over here. So nests of tumor cells, or they may be in the form of glands. Look at the lumen and the tumor cells surrounding it. It is not a true gland but a neoplastic gland. And the stroma, the pinkish tissue, all this deep pink is something like collagen. A lot of this is being formed. This makes the tumor a little hard in consistency. This is called a desmoplastic stroma. The other features are, these will be seen within the ducts also. There can be an intraductal carcinoma somewhere. There is infiltration. And all the features of a malignant neoplasm you people can apply. Cells are large nuclei. Pleomorphism will be seen. Mitosis increased. So all these are features of malignancy. So boldly you people can apply this in the answer. Otherwise you'll have to by heart each and every malignant neoplasm, which will be difficult. And all the stars incidentally indicate that you must know, must write, must get marks. And as I mentioned earlier, there are some variants of the ductal carcinoma. In this, I find that the tumor, there is a knitting by the tumor cells, leaving multiple small spaces in between. This is described as a sieve-like pattern. Sieve-like pattern is used for filtering the floor in the kitchen. And this is called cribriform. Cribriform pattern, a sieve-like pattern is seen. This can be asked as an MCQ. Even otherwise, if a student write, you get a mark for it. And this obviously means we should remember. Tubulotype is another variant. which means you find all the tumor cells are distributed in the form of tubules or glands, and there is a pinkish stroma which they are infiltrating. Tubular carcinoma. If you cannot remember this, just see this picture. So, where do you get all this? PCT, DCT, distal convoluted tubules, proximal convoluted tubules. So, this is just to show the tubular structure. Compare and remember. If you still can't remember, this is a kidney. Where you get the tubules, exactly the same picture is there. So, there is a tubular carcinoma. Another picture of a cribriform pattern, compare and remember. This is a medullary carcinoma, a little difficult in the sense, but I find a large nest of cells which are almost joined together. They say that it is syncytium-like, large cells, and it is surrounded by lymphocytes. Are you able to see the small dark cells throughout? They are the lymphocytes. And the tumor grossly resembles the medulla oblongata, and hence the name medullary carcinoma. Medullary carcinoma. This is another pattern. I am finding small groups of cells. Small groups of cells, and this is not whitish. It is somewhat pale, and then I am finding a mucoid material or a colloid-like material. My professor used to see this and call it as islands of cell in lakes of mucin. So compare and remember. So this is an island you are finding, and it is surrounded by fluid, water. Similarly, there are islands of cells which are surrounded by lakes of mucin. This is called a colloid or a mucinous carcinoma. The Paget's disease of the breast. I was surprised that this was asked as an undergraduate question, but then let us not be baffled by it. I'm finding an indrawn nipple, then there is an eczematous change. In some areas, I'm finding puckering also. There's a pure orange. Okay. The Paget cells are large clear cells which are seen in the epidermis. Epidermis. It is not infiltrating. It is not going into. So these are there. I know it is not very clear, but I can find out some clear cells in this. For those who cannot understand, look at this one, a higher magnification. So these are large cells and they have got a clear cytoplasm, large nucleus. These are called the Paget cells. This from WebPath. And Robbins also gives a beautiful diagrammatic one. I feel that you people can draw this picture. So these are Paget cells which are seen in the epidermis of the breast. And this is a duct. Within the duct also there is tumor. This is called ductal carcinoma in situ. So the Paget cells means there can be an underlying tumor also, infiltrating tumor. So please remember this Paget cells. And a word Paget cells can be seen in other lesions also. And Paget's disease, what are all the conditions where it is? Recently we had seen Paget's disease of the breast as well as the bone. Please remember these two. I had explained this pattern. I will not be going into the lobular carcinoma. This is a lobule and it arises from the terminal duct or the lobule. It is rubbery and discrete. It may be multicentric. See, look at the number of lobules which are there. So obviously it can be multicentric. Sometimes it can be bilateral. So this is the pattern of distribution for a lobular carcinoma. The same picture, lobular carcinoma in situ. What does it mean? Multiple lobules. The lobules are filled with tumor cells and the basement membrane is intact. Always a little picture is worth a million words. Look at this. I am finding the lobule that is filled with the tumor cells, but I am able to draw a clear line around. This is the basement membrane. This is another lobule that is filled with tumor cells. So this is a picture of lobular carcinoma in situ. The cells are uniform, slightly larger than lymphocytes. This is the picture. Once I say in situ means there will be an infiltrating tumor. Once I mention A, that should be B. So lobular carcinoma in situ, in station. Then what is an infiltrating carcinoma? Again, this is not a commercial break that we are having. This is supposed to be a row of red Indians. They have a traditional way of marching, and also it is said that they go in a row, hide behind the bush to attack. And this is called an Indian file pattern. An Indian file pattern. File means a row with a single individual. And similarly, why am I saying it out of context? I find that the tumor cells are in rows, almost analogous to what I see on the right. These are the tumor cells and they are seen as single cells in a row. This is the Indian file pattern which is seen in infiltrating lobular carcinoma. This is usually an MCQ that is asked, and if you write in your theory, you get a mark for it. The spread of tumors. Normal occurrence of the breast tumor is about 45 to 50% is in the upper outer quadrant. For sake of simplicity, just remember it like this: 10, 10, 10, 50, and then 10, 10, 10, it becomes 80. Another 20% will be in the subareolar region. So this will be the distribution of the breast tumors. When you say metastasis, this is the breast over here, and then there is a tumor, it spreads. The first group that can be attacked is the axillary group of lymph nodes. Regional nodes means that can be the axillary group of lymph nodes. And the first node that is attacked, which is reacting to it, is the sentinel node. Sentinel node is a signal node. So it is showing a tumor over here. It acts as a filter, but on crossing it, the other regional nodes are involved. So these are called different levels of infiltration. Surgery will be talking with better. So there is a stage 1 over here, and then the stage 2 or 3, then the stage 4. So this is a lymphatic spread of the breast tumors. Also, there can be a vascular spread. There can be a vascular spread. I think it is too difficult for us to see. Look at this one. It is a patient who is having a breast tumor, and these are all lymphatic channels. The clear space is there. In the middle, I am finding the tumor cells. Lymphatic emboli. Lymphatic emboli are seen. So this is a mode of spread. It can be lymphatic, it can be vascular. This is not very important, but you people can remember there is a classification called the TNM classification. Tumor node metastasis, TNM. And you find it depends on the size of the tumor. So in T1, the size is small, less than 2 centimeters, and it keeps on increasing in T4. There is no lymph node metastasis, N0. Finally, there is metastasis to the regional and the distal regions. And M means distal metastasis. It can be liver, it can be lung, etc. So this is a T and M classification. The prognosis of a tumor depends on the age, size, stage of the tumor, the pattern, and these are the markers, which I'll come to it later. This TNM classification is for your understanding. What are all the investigations that can be done in a breast cancer? One of the foremost one nowadays is a mammogram. FNAC, fine needle aspiration cytology. Look at this mammogram, it is displaying a tumor which is otherwise missed. A mode of doing it is a needle biopsy. Frozen sections, when the patient is on the operating table, you find that a small bit is removed, sent for histopathology, we'll have to give a diagnosis. And histopathology is the ultimate in diagnosis. Immunohistochemistry, the things that we need are estrogen receptor, progesterone receptor. We call it ERPR, and HER2 new protein. These are the important markers which are routinely done for any patient with breast cancer. And cyclin D1 is a recent addition. Dear students, please write this entire panel of investigations, including the immunohistochemistry, because this is asked as a question and you will be getting weightage for it. And what is the treatment for the breast tumors? One is a lumpectomy, malignant tumors not recommended. Simple mastectomy is removing the breast alone. Radical mastectomy along with the axillary pad of fat and the lymph nodes. A silicone implant is subsequently done after it, because all said and done, we'll have to give a social and a psychological uplift for the patient, since a silicone implant is part of the treatment. Chemotherapy and radiotherapy are the other panels of treatment. All the three should be done: surgery, chemotherapy, and radiotherapy. In some institutes like the R.A.T.S Cancer Institute, they do a chemotherapy first, reduce the size of a tumor, followed by surgery. And this is just a diagram of an IDC. I would like you people to draw this in your record. It is a simple diagram which can be easily done. And what is this? I hope you people are able to identify the background of this. I will not say. There are certain things which we must recollect and retain. Must know, no excuse at all, and all these. Desirable to know will be these. Please see the entire list and hope I am justified in having divided the class into two, and these must be retained in your mind. Is it clear? Gracias.